Hello everyone, and welcome to another edition of the Hindu Wellness Series. Today's webinar on addressing premature atherosclerotic heart disease is presented by Kauvery Hospital. We have three panelists with us. Dr. Manoj Shivaramakrishnan, Senior Consultant and Interventional Cardiologist, Kauvery Hospital, Chennai. He has performed over 14,000 invasive cardiac diagnostic and therapeutic interventional procedures. His clinical expertise lies including in abdominal aortic aneurysm, atherosclerosis, cardiomyopathy, coronary artery disease, heart failure, and peripheral artery disease. We have Dr. V. Mahadevan with us. He's a cardio-diabetologist, senior interventional cardiologist, Kauvery Hospital, Chennai. His areas of specialization include complex coronary interventions, image-assisted coronary interventions, and cardio-diabetes care. We have Dr. Punitha Kumar, consultant cardiothoracic surgeon, Kauvery Hospital, Heart City, Tiruchi with us. His areas of interest include adult cardiac surgery, minimally invasive cardiac surgery, thoracic surgery, heart and lung transplant, and robotic surgery. We welcome you all. So before we move on, the audience can post your questions in the Q&A box. We will take up the questions towards the end of the session. I now invite Dr. Manoj to give us an overview on the scenario of cardiovascular diseases globally and in India, especially among the younger population. Over to you, sir.
Let me place my appreciative thanks for the Hindu for facilitating this webinar. And good morning to all my dear colleagues, Dr. Mahadevan and Dr. Punitha Kumar, and all the other attendees who have logged in to understand about this very important topic that we will be discussing today. So my job would be to present to you about a general overview about why do we suffer from premature heart disease at a very young age. So just getting my screen shared. I hope you are able to see the screen in the proper context and hear me as well.
Yes, sir.
Okay, thank you. So how do we address the atherosclerotic cardiovascular disease risk in us? We always know that many of the young generations of our society suffer from acute heart attack and have a sudden cardiac death. And that leaves a shattering impact on the family as well as on the society. So atherosclerosis is a process that starts very young in the age, by age of 8 or 9 years, and then it slowly builds up. And over a period of time, by the time the patient is, the subject is around 70, 75 years of age, the vessel gets stiffer and narrowed, and that's a natural process. So when the atherosclerosis occurs much earlier than that, by the age of 40s and 50s, then we call it as a disease process. So WHO states that the cardiovascular disease is the #1 killer disease. It accounts for 1 in 3 all global deaths, and every death of cardiovascular disease occurs in every 2 seconds. And you would also see that one heart attack occurs on the global scale for every 5 seconds, and someone develops a stroke every 6 seconds in the world. So this is the impact of the cardiovascular disease or atherosclerosis induced disease process in our society. So this is the process by which you would see that cholesterol develops in the blood vessel, and it slowly builds up over a period of time, and it encroaches on the vessel space or the lumen, and then finally narrows the vessel. In the process of this, one would suffer a heart attack if a clot builds up on this deposit of the cholesterol or the plaque that we call as a lipid or a cheesy material. The yellowish cheesy material is the plaque, and the fat content, which has a very high level of low density lipoprotein cholesterol. However, in many of the instances, the clot forms because when the plaque is very, very supple in its early stage and it's very thin, it might erupt and rupture and then attract the clot formation much earlier. And that is the reason why the heart attack occurs very suddenly. So heart disease and stroke statistics 2021 update shows that systolic blood pressure or a high blood pressure and smoking are the first and the second leading years of life lost globally in 2019. High fasting plasma glucose or high blood sugar levels, also high body mass index of obesity, with the first and second leading years of life lived with disability and injury. So it's important that we also regulate all these risk factors like smoking, high blood pressure, sugar, and be physically more active and maintain a good optimal body mass index. Smoking adds to a significantly higher risk along with these above risk factors. Now, if you look at the coronary heart disease in India, which is the heart disease due to the atherosclerosis, narrowing the blood vessels of the heart and causing chest pain or heart attack, compared to the Japanese, Chinese, Americans, you would see that Indians have a multifold increase in the incidence and prevalence of the heart disease, especially the coronary heart disease. What is more alarming is you would see that 40% of the patients are below the age of 45 years of age. And that is a very, very shocking statistics from the WHO. Now, the premature burden of heart disease in the South Asia, if you look at both men and women, you will see the South Asia population compared to the rest of the world has the highest prevalence of heart disease. If you also look at the million death study, which is analysis of 1.5 million deaths in India, and you would see that in the million deaths study from the Registrar General of India published shows that the cardiovascular disease accounts for the largest proportion of patients dying from in India compared to the lung diseases, compared to the diarrhea, perinatal death, chest infection, tuberculosis, or cancers. So it is one of the most prominent reasons why we lose life in our society. It is all known for us that we hear on the headlines of many of the newspapers that many people suffer heart attack at a very young age. It hits Indians very early at a very young age. And these are the prominent personalities which have struck our minds in many instances. There are many more. And we suddenly hear and get excited as well as more focused on prevention of heart disease at this very young protective age group. So it signals danger. If the signal itself is falling on the public, it's much more dangerous. So this is a very, very important aspect of understanding from what we learn from the world. And this is a follow-up of analysis over a period of 25 years. And you would see that if one stays healthy at the age of 60 years, that means a person at the age of 60 years has not suffered a heart attack or a stroke or a chest pain, his likelihood of living another 20 years is significantly higher. So the remaining life expectancy at the age of 60 is another 20 years if you have not had any disease process. At the same time, if a person has had a heart disease before the age of 60, you would lose a lifespan of 7.7 years. If the same individual has suffered a heart attack before the age of 60 years, you are likely to live 9.2 years lower. Indeed, if the person has suffered a stroke, the life lost is about 12 years. So atherosclerosis and heart disease and stroke reduces approximately 8 to 12 years of your lifespan if one has developed this stroke or heart attack or heart disease before the age of 60 years. So it's important that we prevent the heart disease in the young, and they're likely to live longer beyond 60 years of age. Now, if you look at this risk, a 42-year-old man is very common in our practice. I'm sure my co-panelists would agree. His blood pressure is 130/80. Smoking is very common. His LDL cholesterol is 134 milligram per deciliter. So this gentleman who is possibly suspects that he is healthy suffers a heart attack 6 days ago, and he develops a progressive complications, cardiac arrest, he has multiple blocks, and then finally he dies at the age of 42. So diabetes was detected on admission, which is very common, that these are the conditions like diabetes and hypertension doesn't provoke any symptoms until they are far well advanced and manifest in many other conditions. So a family history was noted in this gentleman, where the father had died of heart attack and heart disease at 54 years of age. So you would see that the next generation gets a heart disease about a decade earlier. It's important to aspect all these aspects in a gentleman to analyze, to understand the comprehensive risk. So this is a slogan from the American Heart Association, which was where they noticed that they had a high prevalence of heart disease. And this slogan came in 1978, heart attack breaks a little heart. So certainly that we have to identify so that the family support is there and the person develops well and is protective to the society and the family. If you look at the heart map or the health map of the world, you could see that India has one of the highest prevalence of heart disease. You could see that it is marked red here. Along with China and Russia, the prevalence of heart disease is maximal in these countries. So obesity, if you look at, one has to maintain a normal body mass index, which is 18.5 to 24.9. And any excess of body mass index is likely to contribute to early onset of high blood pressure, diabetes, and various other disease conditions. Now, if you look at the physical inactivity is closely related to onset of diabetes. So the health map of obesity shows that India is colored red. So that means the physical activity scale is very, very less. And most of us do not exercise and do brisk activities. So it is now considered that the sitting or physical inactivity is equal to the risk of smoking. So sitting is the new smoking. Now, if you look at the diabetes, I'm sure my co-panelist, Dr. Mahadevan, who's a diabetologist, would add more insights into this. You will see the insulin syringes here, marked here. This is a health map of the diabetes in the world. India is highest. Next comes to China, Japan, and also the Indonesia, and then the United States of America. So in that situations, we share a very, very prominent prevalence with the United States of America, which is far advanced in its health structure. So the diabetes in the heart is very, very common. And most of the patients with diabetes die of heart disease. 2/3 of the deaths among the diabetes is due to the heart disease. So now important aspect we have to look at is the cholesterol level. We all been talking, and there are many media facts which is giving wrong information that cholesterol can be ignored and we can do away with the high cholesterol. This is again a study over a 6 years period, which looked at that if your serum cholesterol exceeds 200 milligram per deciliter, your risk of heart disease exponentially increases, and you're likely to die of heart disease in the next 6 years. It's important that your cholesterol is markedly kept under control. To understand the public perspective, only about less than 10% of Indians are aware that cholesterol is a risk factor, and 80% of the Indians have high cholesterol, and they're either undiagnosed, untreated, and they do not attach much importance. Now, when you look at the cholesterol, it is also noted that one can safely live with a low cholesterol up to 15 to 83 milligram per deciliter, which is the cholesterol seen at birth in the newborn. So low cholesterol levels are not harmful, and it can allow survival of the human being. Of course, there are additional things that we can discuss during the panelist discussion. Lifestyle modification is a cornerstone and is fundamental throughout the life of the individual. Statins, other drugs which are common, can be discussed during the course. So majority of the cardiovascular disease are predictable and preventable. And we also know that an ounce of prevention is worth a pound of cure. So how do we predict? Now, for this, you need to have certain statistics and certain information. Your identification and measurement of the risk factors. That means one has to assess whether the individual is smoking, what is his body mass index, whether he's a diabetic, whether he's having high blood pressure, and also to know his cholesterol levels. And the interpretation of the risk-related data with the estimation of the risk is very, very absolute, and it needs to be understood, and I'll come to that in later. The use of therapeutic interventions to minimize the disease or the risk also to prevent the disease of development of the risk factors is also one of the important interventions that the physicians and the public health people should involve with. And therefore, this risk assessment significantly contribute greatly to the management of cardiovascular disease prevention. Now, these are some of these risk scoring factors. I don't want to dwell in detail, but these can be applied on a routine basis. There are phone-based apps are available. If you add this blood pressure, body mass index, cholesterol level, and also whether there's a history of smoking, whether there's a family history of heart disease, all these things can be put in and understand the risk. So there are certain special risk categories, like patients under the age of 40 years of age. We certainly do not have a firm data to assess the risk. So especially when it is very common to see heart disease in our population, we have to do a large amount of study in this young generation. Family history of premature heart disease in the first degree relative, like sibling or parents, is important because that adds a exponential risk. Whether there is a family history of high cholesterol, there is a history of diabetes mellitus or early onset of type 2 diabetes mellitus, but the individual has multiple risk factors at a very young age, and also some of the studies that we can do currently by the CT scan, by CT calcium scoring, and also by CT non-invasive angiography can sometimes detect the disease early, which will come to it later. So when it comes to diabetes and heart, what are the numbers? You have to keep your glucose percentile HbA1c less than 7%. Blood pressure should not exceed 130/80. Your cholesterol should be less than 70. So the diabetics per se are a high risk subjects, and they have to bring down their LDL cholesterol to much lower than a non-diabetic, and they should maintain a favorable body mass index of less than 25. So this is a comprehensive slide which will be allowing you to know that your cholesterol and body mass index, the waist circumference, HbA1c, everything should be considered for the South Asian cardiovascular health. Now, what is the impact of having heart disease very early? This is the usual population pyramid, which you will see that the children and the young dependents make the base and large population. Then the economically active group with the attrition, natural attrition and death happening in the elderly dependents. Now, with the economically productive age group between the 20 to 60 years being affected by cardiovascular disease, which is the predominant cause of death in our population, you would see something what is known as a population collapse. You would lose people in the economically productive age group of 40 to 50 to 60, and the children will not have their parents, and neither the elderly dependents will have their children to be looked after. So, however, we all know that we have to follow certain rules in the life, and despite knowing that we should wear the helmet, we do not see many of them doing it. But with significant enforcement, we would see that both the pillion rider as well as the woman has been using primary prevention, which is the way to lead. However, sometimes you will see that this is a truck photograph which I could see. There's two tires at the back and one tire only on one side, which means the disease is far advanced, but you still manage to go on. This is not the way we should approach our life. And certainly it is important that we recognize the disease much early. So I would say that comprehensively, we could address this risk by risk stratification by the various app machines that we have, which can be downloaded in our mobile apps, and also a consultation and a counseling with a treating physician or a cardiologist is very, very important in that age group of 30 to 60 to understand how well is heart health. So I would say A is avoid smoking, B for looking at the blood pressure, maintaining it less than 130/80, C, control the cholesterol, D is very important, the diet, appropriate drugs, and I also add another D, which is the doctor's advice. E is maximize the exercise, F, minimize the fat and lose weight if you're on the obese or higher body mass index, G, monitor and control the glucose, H, quit the bad habits, I, initiate good habits. And I would say comprehensively, everything would work as the vaccine for a healthy heart. So this is a very important proverb from China. The superior doctors prevent the disease. mediocre doctors treat the disease before it's evident. Inferior doctors treat the full-blown disease. So the topic today is prevention of the disease, and that's why the doctors at Kauvery Hospital are committed to the prevention of the disease, and we certainly would contribute much to the society's well-being. So despite the doctor's advice, many would say that the doctor told me to give up smoking, drinking, and overeating, but I found it easier to give up doctors. But changing the doctors from now and then is not going to help you in any way to improve your lifespan and your well-being. So certainly these are certain important aspects that you should follow to maintain a very good lifestyle. So use your heart and know your heart, which is the theme for our World Heart Day. As part of that we are celebrating and having this webinar. I thank you for your immediate attention, and we'll take many questions after the co-panelist discussion.
Thank you, sir, for that elaborate presentation. I now invite Dr. Mahadevan to elaborate on the risk factors and prevention of atherosclerosis. Over to you, sir.
Good afternoon, all. I thank Kauvery Hospital as well as the Hindu for providing a good opportunity to interact with the people. And I profusely thank my teacher, Dr. Manoj sir, who enlightened the nutshell from the origin of atherosclerosis and the way to prevent atherosclerosis for healthy living. So my topic will be somewhat focused upon how much concern we have to giving atherosclerotic events, to understand what is atherosclerosis and what are the disease, how it is progresses, and what are the ways we have to prevent. This is a entire thing that what the bad cholesterol is doing for the blood vessels. It has been greatly alluded by Dr. Manoj sir. Just I will focus. The process of lipid is going to lie on your endothelial or in the vascular tree, not happens in just a day or a month. It happens over years or decades for the matters. So what do you want me tell atherosclerosis? Atherosclerosis is nothing but the lipid driving inflammatory responses. So what the cholesterol is you are eating from the food or from your endogenous sources is going to produce some sort of damage at the vascular tree. And all the organs of your body from head to foot is nourished through the vascular arteries. If there is no blood vessels, if there is no blood, the organ is going to die. Maybe heart or maybe a brain or maybe kidney, doesn't matter at all. So all the organs for its survival requires nutrition that is supplied by the vessel, what we call as the blood vessels. So these blood vessels, the lumen of the blood vessels will be getting narrowed when the lipid starts to deposit on the inner lumen, that is inner wall of the vessels, was thereby reducing the blood flow for the organ. So the lipids, how the lipid is going to produce some sort of destruction at the level of the vascular trees. It is not the lipid alone. So whenever the lipid goes and sits the vessel wall, it invites some sort of inflammatory changes. It lies like any virus or any bacteria comes to your body responds to some sort of fever or some sort of high grade of chills and rigor. That is inflammatory response to the foreign agents coming to your body. But we know the lipid is not a foreign agent. It is required by the body for its function, proper functions, maybe hormone secretions or maybe a cell biosynthesis. We require lipid or we can require cholesterol. But how it becomes a problem then? So it has to be deposited. The lipid has to be utilized at its factory. So whenever things is there, it has to be utilized at this problem. Suppose I'm a person coming from a flat A, I had to go to flat A. I should not go to flat B where it is aligned for me. It is not, it's a foreign for me. Suppose then it becomes a problem. Same thing, the cholesterol should be utilized at the where it is needed. But cholesterol is needed for the blood, not needed for the blood vessels at all. So when the blood vessels sees much amount of enormous cholesterol, when cholesterol starts to lay on the walls of the vascular walls, it invites the problem. So it is there two things. The pathobiology of atherosclerosis has led a novel paradigm that encapsulated two parallel pathways. One is the lipid-laden pro-inflammatory pathways, another the response of the body to the lipid, what we call as inflammatory-related pathways. So initially we had focused on reduction, the way to reduce your cholesterol burden for your vascular tree. But we are holistic approach. We need a holistic approach. In spite of optimal cholesterol control, we don't have reduced any sorts of reduce of CV events. We are not cut down the heart attack. We are not cut down the stroke and all. What might be we need to aggressively address. So apart from cholesterol control, we also take the inflammatory response that is imparted by the cholesterol on the vascular tree. That becomes it. The nutshell. the addressing both the lipid problems on the vessel as well as inflammatory response to the exogenous lipid deposits on the vessels becomes a cardioprotective therapy. So next, so this problems happens as the individual enters the teenage. So as the individual progresses from the teen, there's a shots of fatty sticks getting deposited. If it is not properly given way, if it is proper not addressed at the earliest point, it forms atheroma and a block burden, and it forms a fibrous capsule. At the end, it can block the entire lumen of the vessels, thereby imparting the blood vessels. So what happens? The deposit of fat on the vessels produce problem at the vascular tree level. The lipid entry invites the problem of leukocytes. So as like virus entry or like bacterial entry, your blood vessels has so much defensive policemen that enters to kill that virus, that enters to kill that bacteria. Same thing when the lipids enter into the vascular tree, it touches the endothelium, your immunity has been triggered in a wronger way. This leukocytes comes to that, there is a fight between the lipid and the leukocyte that we call foam cells. And if it's not properly addressed, what happens? There is a growth of muscles from the inner layer, from the outer layer to inner layer, that reduces the luminal narrowing. So one problem is happening at the level of the fight between the lipid and your leukocytes, that forms a seat of the fight. The seat of the quarrel is in the intima, what we call as a internal layer of the blood vessels, thereby inviting the growth of your fibrous tissues and smooth muscle proliferation is there. So automatically the fight and the encroachment happens in the luminal narrowing, that produces problem. If the problem happens in the heart vessel, we call it a chest pain. If the problem happens and the legs, we call it the claudication. There may be some sort of terminal difference, but everything, the problem underlying pathobiology is luminal narrowing into the fight between the lipid and your leukocytes. If the block is not properly addressed this point, if you don't address the lipid burden, or if you don't properly treat the inflammatory response at this point of time, there may be a block progression can be there that can go for a description. Patients going for any form of acute coronary syndromes, that patient may present to clinic with myocardial infarction, which is very, very dangerous. That is a common culprit for the human race till now. And how we can prevent? So we are saying there are many drivers and contributors there for this. Is what are contributors? How I can change this problematic milieu in a problem-free manner. So we know heart is the seat of the pump organ that going nourishment for all organs in total. So there are non-modifiable risk factors which we can't modify. I can't fight against age. So I can't fight. I want to be younger, right? It's no one can fight that I don't want to be older. And gender inequality is there. Even though we say my heart disease, the myocardial infarction is very common in male, there is not much disparity in the females touches the postmenopausal period. And genetic factors, as clearly told by my teacher, Dr. Manoj, the familial genetic inheritance in terms of vascular problem or vascular biology is very, very, very common, especially in people young age. People are having a heart attack at the age of 39 years or 40 years, or maybe at risk of harboring some other form of genetic factors that is influencing his vascular biology in a wronger way. And race and ethnicity, as we pointed out by Sir, Indians have high burden of heart disease, high burden of hypertension, high burden of dyslipidemia, whatever you can see that is going to kill your heart, we have an enormous amount. And what is the pathetic situation? We have a decade earlier onset. So we have MI or we have heart attack in earlier decade than the western part of the globes, and mainly because of so much of problems that can be easily modified. So we have heart attack at the earlier age, we get diabetes at the early age, we get high BP, which are the reasons that can easily tackle and address at its core from the earlier originators. So high BP, yes, you can control it well, you can control it from its origin. Even we have so much of medications, we have so much of dietary patterns that can be incorporated to reduce high BP. Smoking can be stopped from the day one. So many of the people still excuses. So I will cut down smoking slowly. They will never cut down the smoking if they have some sort of excuses to cut the habit. And diabetes mellitus, yes, it requires monitoring, it requires treatment, because we have more number of diabetic individuals in India compared to all other parts of the globe. We can have a diabetes capital, and we have to translate this diabetes capital to diabetes care capital if we want to prevent diabetes-related complication. And physical inactivity, yes, is as far as the like of smoking. So physical inactivity, because of modernization of the culture, modernization of your activity, in the physical activity becomes very, very nil. from the school. Initially, I used to go by school by cycle or by walk, but when newer generations, or even the school is near, they are going by a two-wheeler or sometimes of locomotives rather than going for a walk by themselves. The obesity we see common childhood obesity, that is the problem. This obesity is not like what we say, as Sar pointed out, is like ample-like obesity. So many of the people will have higher tummy. The other way around, we used to usually call Indian as thin fat individuals. So many of the things you may think fat means the people will be very stout and will be very good, big enough. But we are thin, but we harbor much amount of high cholesterol levels that is not good for our body. And whenever the cholesterol accumulates in and around the abdomen, it is more and more atherogenic. It invites inflammation. It aggravates your immune modulity in a wronger way. So central adiposity is as equivalent for an inflammatory response that is happening across the body. So high waist hip ratio or central obesity is a marker of the people to get vascular events, maybe heart attack or maybe stroke, and high blood cholesterol because early exposure. And nowadays, even the children are exposed to high fat diet, high carbohydrate. But if you ask the consumption of vegetables and fruits, very, 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 very minimal. Even the snacks are made up of high fat diets. Even the routine diet, what they are going to take, which was earlier very rare phenomena. So here the oil soup items will be cooked only for during festival seasons. But nowadays we are taking another form of oily fat items in our day-to-day life. It is mainly because of easy accessibility. 24/7 you can get all the high fat diets, all the high carbohydrates. But on the contrary, the consumption of vegetables, the consumption of whole grains, the consumption of fruits has become very, very, very low. And physical inactivity on the other side is become negligible, even is very, very negligible. So the imbalance is shift in a improper way that is going to further thrombotic milieux. So one way we are taking more calories, on the other hand, we are not spending the calorie shops. So all the things is going to stay in our body in an enormous fan. So that becomes a danger for all the organs in total. And we can see how we are going to prevent. So we have to prevent all the modifiable factors, like you have to give importance for diabetes control, you have to importance for hypertension, cholesterol, and you have to increase physical activity. And on the top of that, we must also address the problems happening at the level of vessel walls. So you see, when the block progression starts here, there's a primary prevention. You have to assess the risk factor and you have to tackle the risk factor. If you don't tackle or you don't address at this point of them, the progression of atherosclerosis is accelerated, and then go for a blood clot on the top of the atherosclerotic burden that gives an acute event, maybe a coronary event or maybe vascular event happening at the level of the brain or in the peripheral vasculature, maybe a loss of limb or loss of life can be there. And atherosclerosis prevention should be the main focus, especially in terms of primary prevention. Even if there is, you can go for a primordial prevention before the emergence of fatty disease. So we have to encourage a child, you have to encourage school-going children to adopt healthy lifestyles, ask them to go for a good physical activity, cut down high fat, exposure of high fat, high cholesterol or high carbohydrate, encourage them to go for high fiber diet, whole grains. That has to be taught from the school day onwards, because the fatty streaks happens when the individual runs over the teenage periods. It's not happening at the age of 50 or 60. The problem starts, the problem kick starts at the individual when it crosses the teenage. And if you have evidence of atherosclerotic burden or a clot burden, maybe patient have gone for some sort of scan over the carotid, they are saying the carotid thickness is very huge, then they have to go for a modification of the process. That also includes risk factor modification on the top of that medication that can be endorsed or then being prescribed by your physician. If the problem happened, that becomes secondary preventions. So after the incident of any event, vascular event, maybe myocardial infarction or maybe a peripheral vascular event, interventions or any stroke, that becomes a secondary prevention. And the problems high encourages you have to go for a primordial prevention. This is the prevention nutshell. So first, you check your sugar levels and you check your cholesterol in the blood. That has to be brought under control. And as we have to consume whole grains and vegetables and fruits in our day-to-day intake, rather than hunting for more fatty and more carbohydrates diet, and go for a physical activity, maybe a jog or a walk, even dance can be practiced, and keep your weight often. You keep your BMI as low as possible in the ideal range, as advised by your physician, for optimal outcome. And you must cut all the bad habits, maybe a smoke or maybe alcohol. It has to be stopped. Immediate effect should be happen at this effect. But you can't give way that I will reduce over the due course of time. That is not, there may be excuses that there might not be a treatment at all. And the frequent monitoring is very, very essential. Any chronic illness requires frequent monitoring. As like giving exam for all the students every quarterly, every halfly. So we can, there are chance for us to rectify. The test is meant to rectify your problem, not to have some sort of harm or some sort of fear for your mind. So do the test periodically, consult a doctor for optimal benefit or optimal outcome in your day-to-day life. Thank you.
Thank you, sir, for elaborating on the preventive aspects of atherosclerosis, its risk factors and the modifications are required. Now I invite Dr. Punita Kumar to speak on minimally invasive cardiac surgery. Over to you, sir.
Good afternoon, everyone. Am I audible?
Yeah,
you're
audible. Yes, you're audible, sir, but your video seems to be turned off.
Whether my screen is shared? Are you able to share? See the screen?
Yes, sir.
Okay, thank you. Good afternoon, everyone. On behalf of Kauvery Heart City, I sincerely thank Hindu for giving me an opportunity to present in this webinar. I will discuss about the surgical options available for premature atherosclerotic heart disease and what are the minimally invasive options for that in the surgical options. The surgical options available for atherosclerotic heart disease is mainly coronary artery bypass grafting. What is coronary artery bypass grafting? It is giving blood supply to the blocked vessels. As commonly say for a heart attack due to heart blockage, we bypass with the natural with the old tissue, either left internal mammary artery or saphenous vein graft. To bypass those blocked segments, we connect to the proximally to the aorta and distally to the coronary artery beyond the blockage. By giving the blood supply to the ischemic area, the ischemic myocardium will restore its own function, viability, and the patient will be relieved of the anginal symptoms. Next slide. This image is explaining how we are connecting the vein grafts to the blocked vessels. Mouse. This image is showing the epicardial surface in the surgeon's view. Here is a left anterior descending artery. Mostly coronary artery bypass surgery will be performed for left main disease and triple vessel disease, triple vessel coronary artery disease. What surgeons we are doing for a treatment of atherosclerotic heart disease and triple vessel disease, we are bypassing the blocked vessels with an left internal mammary artery. It is the branch of subclavian artery. We are providing blood supply to the ischemic area, and with the saphenous vein graft taken from the legs, we are giving blood supply to the. This is the right coronary artery. This is the left side coronary artery. We are giving blood supply from the aorta. This is the main blood supply for entire body. From this one, we are connecting and giving blood supply to the ischemic area. Next. What are the options available in coronary artery bypass grafting? We can do it in on pump with the help of a heart-lung machine, or we can do it off pump if the patient hemodynamics is everything is okay. and beating heart and arrested heart in on pump. In off pump, it is a beating heart bypass surgery. What are the approaches we are using for coronary artery bypass? Most commonly, we are using sternotomy approach. We are cutting a bone in the center of the chest and we are exposing the heart. Then the surgical options available, approaches available are minimally invasive cardiac surgery and totally endoscopic, and then robotic CABG. Next one. Depending upon the number of grafts we are placing, the CABG can be single graft or 2 grafts or a triple graft or a quarter bypass. This image is showing the number of grafts given to the ischemic area. This one is a single graft to the LED. This is a 2 grafts. This is a 3 grafts and 4 grafts. This is how we open the chest, and we are opening in a standard sternotomy incision. We are opening the chest and we are bypassing from here the main blood supply. From here to here, we are giving a connection. So the ischemic portion beyond the blockage, the blood vessel will get the blood supply. Next one. On pump CABG, on pump bypass surgery is we are using the heart lung machine. We are diverting the blood supply from the deoxygenated blood and getting oxygenated, and we are giving the oxygenated blood to the aorta. So the heart will become supple and we can do the bypass surgery. That's fun. This is a setup heart lung machine with a surgeon standing, and we are connecting the venous drainage, and then we are giving the arterial blood to the patient. Next one. Next. This is how the on pump CABG will look. This is the venous drainage, and this is the arterial canal giving oxygenated blood to the aorta. So the heart will become supple, and arrested heart we are doing the anastomosis. Next one. Off pump CABG is basically with the help of tissue stabilizers. This one is the starfish and this one is octopuses. With the help of tissue stabilizers, we are not stopping the heart. On beating heart, we are stabilizing the epicardium and we are opening the coronary artery. And with the help of intracoronary shunt, we are anastomosis, and we are creating anastomosis, and we are doing a bypass. With the help of tissue stabilizers, we can lift the heart and we can do the anastomosis, provided the hemodynamics are good and the patient is tolerating well. This is the intra picture. This is a saphenous vein graft connecting to the LED, left anterior descending artery. Next one. This is a traditional sternotomy approach used for bypass surgery. This is the minimally invasive bypass surgery. Without cutting the bone, we are making a thoracotomy, mini thoracotomy incision, and through this approach, we are adjusting the vessels, and then we are doing the bypass surgery. That's right. This is how the system will look in minimally invasive. With a small thoracotomy incision, we are exposing the LED, and we are harvesting the lima through this little space, and then we are connecting left internal mammary artery to the left anterior descending artery. Yes. Then comes totally endoscopic coronary artery bypass grafting. This one, with the help of thoracoscopes, endoscopes, we are using connecting the conduits to the targeted coronary arteries. Yes. This is a robotic CABG. With the help of robo, the same anastomosis we are doing with the help of robo and robotic instruments. Yes. This is a opened coronary artery with the intracoronary shunt establishing the flow. This is the intima, and we are creating anastomosis, the saphenous vein graft. This is the intima of the saphenous vein graft, and this is the intima of the coronary artery. Next one. This is how the setup will look in robotic surgery. Next one. These are the grafts available. This is a left internal mammary artery. With the same internal mammary artery, we can do we are giving arterial circulation to both the coronary arteries. Next one. Another conduit available is saphenous vein graft. We are harvesting from the leg, and we are connecting from the aorta to the blocked coronary arteries. Next one. This is another type of bypass surgery in which the radial artery will be taken. This is the arterial supply to the hand. One artery we will take after performing the Allen's test. One artery is sacrificed, and we will be anastomosing into the aorta to the blocked vessels. Next one. This is an intro picture showing how we are doing performing the LED anastomosis. After opening the blocked vessel, distal to the blockage, we are giving a blood supply. We are creating anastomosis and we are giving the blood supply. This is a left anterior descending artery. We are opening it and then we are putting a shunt and then we'll create anastomosis. This is an intracoronary shunt. This is a beating heart CABG without a heart lung machine. We are performing anastomosis. This is a simplified view of a diseased heart before surgery. This picture is showing blockages here and blockages. This is a left main coronary artery. This is a left anterior descending artery. This is the obtuse marginal LCX and obtuse marginal artery. What we are doing is a creation of anastomosis, and we are giving a blood supply through the left internal mammary artery to the left anterior descending artery. This is a venous graft from aorta to the right side coronary artery, and from aorta to the obtuse marginal OM branches. That's one. Thank you.
Thank you, sir, for detailing the various surgical methods. We will now move on to the Q&A session. So, does atherosclerosis have any symptoms? And we have a connected questions. Can we reverse atherosclerosis? Dr. Manoj, would you like to take the question, sir?
Yeah, it is certainly possible to reverse atherosclerosis if it's identified much early in the course of its progression. Dr. Mahadevan showed a good slide with the picture where it evolves over a period of many decades. So if you're understanding that your cholesterol is high at the age of 12 or 15 or even 20, 25, and the atherosclerosis is a process which is there in every one of us. It doesn't happen in selective people. It's a natural process. And the only thing, it takes a long period. In some people, it comes and appears much earlier. So therefore, if you have a high cholesterol, if you also have many other associated clustering of other risk factors like smoking, obesity, also diabetes or hypertension, if you have multiple such risk factors, it appears much earlier. So it is not a one single factor. Cholesterol alone doesn't cause. It's cholesterol in association with many other things, which is why it's called risk enhancing factors. So cholesterol and associated other risks like high blood pressure, inactivity, and inflammatory response are all risk enhancing factors. If you have all these things together, you are likely to have a progressive and faster atherosclerosis. And in that, we can certainly reverse that if it's identified early, when you institute good discipline in the food and also in your physical exercise, in your lifestyle, and also sometimes, as I said, you may need a doctor's advice to see whether a drug or a specific drug is required to keep all these risk factors in optimal control, which includes the cholesterol, the diabetes, the blood pressure, and also your body weight. So for all these things, we need to comprehensively address, and we can certainly reverse. At the same time, if the block in the arteries is fairly advanced, like 70, 80, 90% or so, it is unlikely that those blocks will be reversible.
Thank you, sir. Dr. Mahadevan, there's a specific question from a participant. Can fatty liver lead to heart attacks? Sir, your audio is turned off, sir.
Sorry.
Yes.
It's a good question. It's a good question. Because fatty liver can be a part of a metabolic syndromes. People with metabolic syndromes are having high risk of developing heart disease. And fatty liver, the cholesterol or the form of fat deposited in fatty liver is entirely different from what they get deposited in the blood vessels. There is much difference in the density of the proteins that is getting deposited in the fat, and the fat of the liver, fat of the liver, and the fat and the cholesterol. But in fatty liver, as a marker for insulin resistance, we can take as a marker for insulin resistance, as told by Sat. If we get diabetes yearly, especially diabetes is very common in people having the fatty liver. The fatty liver as well as the diabetes, when joined together, there are papers or research is going on which shows clearly that people having fatty liver and obesity or central obesity are at risk of developing vascular events, maybe heart disease or maybe a stroke for the matter.
Thank you, sir. There are a couple of questions on diet. So, what are the diets or food that should be avoided to have a healthy heart? And where the lipids come from our diets and deposit in the heart vessels? Are they mostly from carbohydrates or fat foods? Dr. Manoj, would you like to take the question, sir?
Yes, certainly. Yeah, I think it's a very, very important thing that we all go through your mind every time we think about the diet and also the heart disease prevention. So, diet is very important, and the fat content should not exceed more than 20% in your total content, and especially the saturated fat should be avoided. So, you can have monounsaturated or a polyunsaturated. If it's polyunsaturated, it's much more preferable. Saturated fat in the form of butter, ghee, and also the dalda or vanaspati and many other saturated fats in the form of cheese ought to be really taken in a very, very limited amount. So a moderation is, we don't prescribe a fat-free diet. Fat is important because fat is required for absorption of various other vital vitamins and many other substances. And fat is also necessary for the integrity of each and every body cells. The body cells have fat and cholesterol in their cells. We don't want excess cholesterol. And that is why I showed that your cholesterol need not exceed 50 milligram per deciliter, which is what we see or much less in a newborn. So you can certainly look at the fat content, but it's not necessarily the fat content in the diet that is contributing. Excess carbohydrate is also contributed to conversion into a fat substances. When you have carbohydrate in excess of your calorie requirement, it gets transformed and stored as fat. And therefore, it is now considered that a high carbohydrate diet is equivalent to high fat diet. So carbohydrate is a new fat, and therefore we have to balance both the carbohydrate intake and also the fat intake. Protein can be more because it helps in both maintaining the glucose profile well and also keeping the fat content less. So therefore, we have to balance a 30% carbohydrate, a 30% protein, and maybe 20% of fat, and more. The rest will be fiber diet and also the fruits and nuts. So as Mahadevan showed, Dr. Mahadevan showed, fruits and nuts should be an essential part of everyday diet, which gives us fiber and also maintains the digestive process as well as the gut inflammation. He talked about gut inflammation. The gut inflammation is also very important and to maintain the integrity of the gut. In fatty liver, also there is a profound inflammatory responses and inflammatory markers. So therefore, all these inflammations can have impact on the blood vessels, because whatever we eat is absorbed and carried in the human body through the blood vessel, and blood vessel has the first impact of all these adverse responses. So both the fat as well as carbohydrate contribute to the cholesterol and fat in the human body, and therefore needs to be moderated.
Thank you, sir. Just to go back to something that you had mentioned about lifestyle modifications being the cornerstone. Apart from diet, what kind of modifications are essential, sir?
Yeah, I think the next comes the physical activity schedule. And physical activity means aerobic activities. It is not the isometric exercises. Aerobic and isotonic exercises is what is most preferred and is heart friendly. So heart friendly exercises are a casual walking or a brisk walking. If you have no skeletal disease or disorders that prevents you from brisk walking, you can certainly do brisk walking. You can do running or jogging, and you don't have to do running for a marathon. That's for a higher level of fitness, and that needs to be in a monitored scale. So if you do a higher level of physical activity, it always have to be in a very, very monitored fashion with a sports medicine or a sports specialist. Otherwise, there are many other factors. That is why we see people losing their life soon after a very hectic activity at the gym. So these are some of the things which goes unmonitored. And I would say equally the dancing, skipping ropes, cycling, and also swimming. Swimming is the best form among all the forms of exercises because it exercises all the muscles in the body from head to toe. And if there is a swimming possible and you know to swim or learn to swim, I think we should always consider that as one of the best forms of exercises. Isometric exercises in the form of weights training, push-ups and pull-ups, it causes surges in the blood pressure, instant surges, instant load on the heart, and can certainly cause various chaos inside the human body and stresses the heart more than isotonic and aerobic exercises. So there are many of these exercises which needs to be continued at least 15-20 minutes a day or 150 minutes a week. You don't have to do necessarily continuously every day. You can give 5 days a week and 2 days a break and then have. But what is the prescribed exercise about 150 minutes in a week is what is an optimal way of exercises. You could do more depending on your optimal ability to endure more exercises depending on your fitness.
Thank you, sir. Dr. Mahadevan, there's a specific question on blood pressure levels. Are blood pressure levels the same for all ages? Here, in this case, there's a person who's aged 80 who had undergone CAPG at the age of 65 and has a BP of 140/80. So, is this normal?
Well, valid question, because as per the recommendations from the various forums, they recommend whatever the BP you want to keep, you can, if even 120/80, which is a norm, we will call as a normal BP, is if it is acceptable by the individual. There is no any adverse events because of this 120. If you want to keep, if you want to keep the BP of 120/80 without any adverse events, is a good BP for the individuals. The age is not a major constraint to reduce the BP. Suppose patients developing some problem with the reduction of the BP, or patients having some problem with the medications, so you can have some sort of lenient benefit in terms of control, but the benefit should not be wide range. So in my view, we can keep less than 120/80 if the patient is able to tolerate the BP and there is no ill effects from the drugs we have prescribed. If there is any issues, you can keep around 130/80. And there's diabetic, or if there is any other form of problems, maybe vascular events or something else, you make an andros 130/80, maybe optimal BP control, less than 130/80.
Thank you, sir. Dr. Punitha Kumar, is it possible to tell us how robotic surgeries have evolved over the years for cardiac, in the field of minimally invasive cardiac surgery, sir?
Actually, minimally invasive cardiac surgery now is the upcoming era. Previously, the standard sternotomy approach, the post-op recovery for the patient, the bone healing period, it will take 3 months. So the patient has to do minimal activities only. They should not lift weight. And initial the 3 months, the bone healing period, they have to do only minimal activities. But in the advantage of minimally invasive cardiac surgery and totally endoscopic and robotic surgery, the incision is less and we are not cutting the bone. Through the small incision without cutting the bone, we are able to perform the same bypass surgery and same grafting. With the help of these surgeries, the post-op recovery and ICU stay and ward stay, total recovery for the patient is quick, so they can resume the activities, normal activities soon. It is a benefit for the patients. And robotic surgery is an upcoming era. It will reach all cities soon.
Thank you, sir.
Thank you.
There are a couple of questions on statins. Dr. Manoj, somebody wants to know, how do statins help and do they have any side effects?
Statins are largely beneficial and there are very, very minimal side effects. And statins have been in clinical use in the last 30, 40 years, and many lives have been saved. I would say next to the antibiotic or penicillin that was invented by Fleming, the next more important discovery was the statin, because these are the two important things that prevented many deaths in the world. When we talk about prevention, infection was, or communicable diseases were very important those days, like a plague and tuberculosis and many other diseases like cholera. And when penicillin came, penicillin was a lifesaver. So similarly, for the heart disease prevention, if there is a need to take statin, which you could do it in consultation with your physician or a cardiologist, depending on your risk profile, how much lower you have to bring it down, that will dictate whether you need cholesterol lowering medicines or not. Some people may require additional medicines over and above the statins. Statins are very, very beneficial. Some of the common side effects would be body pains and muscle pains, but many of them are able to get over this in the initial phase. And there are many, many millions of people continue to benefit from statins over a period of many decades. So there need not be any confusion or any kind of a doubts in the mind or dilemma to understand whether the statins will cause any adverse effects. It's certainly beneficial. If we can reverse the atherosclerosis, it is only with reducing the LDL cholesterol through a very good intensive dose of statins. Sometimes in very hereditary patients with a very high levels of cholesterol, sometimes we'll see the LDL cholesterol in 300, 500, 600. The statins may not be equally beneficial, but we may have to add on many other medications like a non-statin medications, which will also work along with statins to bring down the cholesterol. So rarely there are patients come up with development of diabetes, but that is very minimal. And the risk of developing diabetes from statin use is very negligible as compared to the benefit that it confers by prevention of heart disease and also stroke.
Thank you, sir. Just to put across a basic question, should all chest pain need medical attention, and when should a person seek a doctor's help for chest pain? Dr. Manoj, would you like to take the question, sir?
Yeah, certainly. I think it's a very important thing. One of the ways of prevention of heart disease and heart failure or a major progressive heart disease is also to understand that when you have some kind of a pain in the chest, it could manifest in the center of the chest. It could come to the shoulder. It could come to the other shoulder also, not necessarily left side. Sometimes it can happen to the right shoulder. And one of the more typical symptoms is the pain or ache in the jaw. If you have a constricting pain in the neck and also involving the jaw, it's almost always certain that the pain is due to the heart disease. And sometimes some people get pain in the back of the neck and also the back of the spine, upper back. So we need not ignore all these symptoms. And if you suffer from any of these symptoms, I would say that you go to the nearest physician. If the physician is far away, go to the nearest laboratory where you can get an ECG done and try to get in touch with the treating physician or a family physician or a cardiologist if you have an access to the cardiologist with that ECG and see if the ECG is abnormal. At the same time, I would caution that a normal ECG at the time of chest pain does not rule out a serious heart disease. You may perhaps have to be in a period of observation for a couple of hours and do certain tests like troponin test, which is available now with just like you check the sugar levels with a drop of blood or with a prick point in the finger. A single drop of blood will tell you whether you have already suffered a heart attack. So a period of observations, ECG and a consultation, and sometimes if the doctor directs a troponin test, all these things would ascertain whether the pain you are experiencing is due to the heart disease or something else. So certainly I would say don't ignore, especially when we see many lives are being lost because of want of ignorance of understanding that this pain, or they come very late, even 2-3 days later after the chest pain, they arrive at our facility. We are unable to help them because the muscle is much farly damaged and they are in a profound heart failure and many other complications that would set in. So don't ignore the chest pain. Go to the nearest doctor or physician and see whether an ECG is required, and then ask and discuss with the doctor whether it could be a heart-related pain or otherwise. Sometimes if the treadmill test may be required, if the ECG is normal and a second ECG is normal and also the troponin test is normal, a treadmill test may also be performed. And these are all at the discretion of your treating physician. So you should seek attention if you experience any pain.
Thank you, sir. Dr. Mahadevan, would you like to tell us on preventive health checks? What would the advice on preventive health checks?
Yeah, good. As told by Dr. Manoj, ounce of prevention is far better than a pound of cure. So as Riley told, we have harbor, as an Indian, we have a large number of diabetes population, hypertension, dyslipidemia, and sedentary lifestyle. We have so much of things. And early exposure of fatty rich diet, carbohydrate. So we see many number of young people succumbing to these sorts of atherosclerotic events. So it's better to prevent it rather than going for a cure, because cure is a catastrophic. When patients get in the myocardial infarction, it's a catastrophic event for the individuals. It's a battle between the life or death. But it's easy way for them to do a preventive aspects, and we have much number of preventive health checkups here and there. And you can do whenever your age crosses more than 25, 30. If you have a family history of heart diseases, especially if you have any heart attack in the early ages of life, if your father had a heart attack or your elder brother has had some sort of coronary events or vascular events, please try to do the checkups frequently and alterate and rectify your problems as per your healthcare professional's advice. So I recommend to do a preventable checkup often, especially in the high risk peoples when the obesity is there, when they have high risk habits like smoking, alcohol consumption. If the family is strongly supportive of any heart disease or maybe vascular events, it is better to check.
Thank you, sir. We'll take one of your questions before the closing remarks. Dr. Punita Kumar, do you see a lot of misunderstanding or misconceptions that surround cardiac surgery, sir? Any specific queries that patients ask you? Any misunderstandings as such?
Yeah, most of the patients, they are assuming after undergoing open heart surgery, after undergoing bypass surgery, whether we will be able to receive the normal work. This is the most common question after surgery, before surgery, the patients and the relatives they will ask. Actually, for standard sternotomy approach, we are doing surgery means initial, actually, while at the time of after 3 days and in ICU and 4 days in ward, we are actually discharging in 6th or 7th POD. While at the time of discharge itself, we will ask the patient to climb up the stairs and they are able to do the daily routine. At the time of discharge itself, they will be in that stage. But only advice what we will give, they have to restrict the activities like don't lift heavy weights like that, because it will cause sternal instability and there may be some wound problem. But after 3 months, once a bone heals well, they were able to do the normal routine activities what they were doing previously before surgery. They will be able to do. This is the most common question most of the relatives and attendants they will ask. But after surgery, they are not going to take bed rest or bedridden, not like that. They can do the routine activities just like as they are doing before surgery.
Thank you, sir. Dr. Manoj, this question is for you. How do I know my heart is healthy?
I think that's a wonderful question. Heart healthiness is from various parameters. First of all, it also involves about the mental health of the individual, because the psychological stress also stresses the heart in many ways. And sometimes many of the patients suffer from heart attack because of the intense level of psychological stress. So we have to be psychologically stable and also comfortable in our mind. Secondly, various other parameters. If you think your optimal body mass index is 24 and less, and your waist hip ratio is also optimal, your blood sugar is HbA1c is less than 6%, and your LDL cholesterol is overall in a low risk individual less than 100 milligram per deciliter, and you perform a treadmill test and you were able to perform to the required level of endurance, and the exercise ECG or the stress ECG is normal, I think you can certainly be sure at that point of time that you are quite healthy in your heart. And if you sustain all this in a very disciplined manner with the food discipline, lifestyle discipline, and also in periodic consultation with a physician or a cardiologist, I wouldn't say you need to visit the cardiologist every month or 2 or 3 months. A once a year visit would be enough if you're past 30, and especially above 50. I would say you should visit your physician twice a year, unless if you're staying healthy. So all these parameters would tell you you're quite healthy. Now we have what is called a CT calcium scoring. CT calcium scoring is just a simple test. Just have to lie down on the CT scan machine. In about 3-4 seconds, it will tell us about you have any calcium deposit in your coronary arteries. If your calcium score is 0, definitely you can be ruled out that you don't have significant blocks in the arteries. So if the calcium score is between 100 to 300, you're in the intermediate probability. If the calcium score is more than 300, you need a further assessment with a specialist cardiologist. So a calcium score of 0 will definitely tell you that you have a very healthy heart, and that is all required and prescribed only after initial consultation. So there are various parameters that could tell you that you are having a healthy heart by all means.
Thank you, sir. Any closing remarks, sir? Dr. Manoj, Dr. Mahadevan, and Dr. Punita Kumar, please.
I would say if you walk a mile, you would earn miles and miles in your life. And that is what I would say, that physical inactivity should be definitely addressed in our society. And it is not enough that we eat many things, but also we should burn those calories and maintain an optimal body mass index. And that is also the driving factor for the diabetes, the fatty liver disease.
Dr. Mahadevan, your closing remarks?
Yes, use your heart to know your heart, and you must fight obesity and defeat diabetes, halt your salt intake, and bad cholesterol is always bad.
Thank you, sir. Dr. Punita Kumar, any closing remarks from you?
Basically, avoid stress and be cool and keep your heart healthy, happy, healthy. Thank you.
Thank you, sir. So that brings us to the end of this webinar. I thank the panelists for sharing your views and elaborating on cardiovascular diseases, prevention, and the surgical methods. I hope it was beneficial for the participants. I thank all the participants for taking part in the session. Thank you, one and all. Thank you, sir. Thank you.
Thank you. Thank you.
Thank you.